Hello, hello, hello. I want to apologize. We attempted to use that reusable link and it did not work. What it did was it just set up a recording. So I couldn't see you, or maybe it did work. I don't know, but I wasn't sure. Hi, Leslie. How are you? Welcome, welcome, welcome. I'm going to let a few more people get in before I begin. How are you? Are you all ready for some cardiovascular? Let me know. Talk to me. Talk to me. Type in the chat. Type in the chat. All right. So, yeah, we did get a late start, but we're here. Hello, Nicole. Welcome, welcome. Hi, Mr. Sandeep. I think Ms. Mills is somewhere close. Hi, Kimberly. You're ready? That's what I'm talking about. That's what I'm talking about. So I'm going to get started. And I guess when everyone's here, they'll come. All right. So don't forget to like, subscribe, and share these sessions because the more you do that, the more people come, and the more people come, the more content we make. So thank you in advance. All right, just want to say welcome to my instructors. I believe Miss Dolly will be showing up. I see Ms. Mills. How you doing? Hi, Mr. Sandeep. And hello, hello, hello to you, coders. Welcome. All right, so the purpose of these guided sessions is reinforcement, not reinstruction. I was just told yesterday that someone said, hey, you spend 20 minutes in the beginning talking about things that you don't really need to talk about. Well, let me tell you, the purpose of this session is to guide you through your class. That's it. Now, any instruction that I give, that's just me. I'm kind of extra, right? And anytime I can instruct or there's an opportunity, I'm going to take it. But the purpose is to really guide you through your LMS. So this is for your gold, um, platinum, MCDC students, and people who are gold that aren't in the LMS. All right. So we're going to discuss coding guidelines too and their relevance to the medical coding exam. So I'm going to use this opportunity to kind of give you some test taking techniques. I'm going to strengthen those test taking techniques. I hope to by using FTRs and those MJ gems, those jewels. We're going to hopefully I'll foster a an engaging discussion. So use the chat. Definitely tell me what you're thinking. I want to encourage you to be forensic and use your forensic skills when you're solving these scenarios. And I want to be that accountability partner. Yeah, I'm your instructor, but I also want to keep you on task. And I want to create a forum to answer student questions. So, not just me, you've got some of the best and brightest in the chat. They call them subject matter experts in this field. So, ask away. All right, we have a disclaimer. This class is exclusively for AMCI MCDC students and Gold Online LMS students, as well as Gold YouTube students. And anyone else may that are watching, you may attend and you can participate. But just so you know, that's who we're really focusing this content and building this content around, but you are more than welcome. All right. So these sessions are kind of like flip or reverse classroom model or style. In other words, you should have already just completed that subject. So today we're talking about cardiovascular. So you should have completed the cardiovascular module, but if you haven't, it's okay, right? Okay, got an announcement. Next week, November 23rd through the 30th, AMCI will be closed for the holidays, so there'll be no classes. Enjoy your family and friends. Okay, Now, when we are doing test taking techniques, we only have one rule, just one. Type in the chat if you know what that rule is. Hi, Miss Dolly. How are you? Hi, A. Burrows. How are you? And if I missed you, please forgive me. Hi, Kimberly Hopwood. Okay. The rule, if you know, put it in the chat. The rule is we do not use blind process of elimination. If you strengthen your guideline knowledge, you do not need any tricks. In fact, it's quicker. It's quicker if you don't use it. Learn the correct way. You can apply it on your exam and in the real world. Okay, I want to remind you that the 2026 Optum textbooks are here. This is the AMCI promo code. So if you want really good discounts like 30%, use that promo code. And you can also use it for the CPT. CPT, ICD-10-CM, if you're studying for your CCS, that PCS manual, and the HCPCS Level 2. HCPCS Level 2 won't be out until the end of the year. So you got to wait a little bit. So if you want to wait until you get them all, you can. You could save a little bit on shipping if you ship them at one time. But you know what your story is. You know what you need. So definitely, go in the path that you need to go. And yeah. Oh, for people that are studying for the exam, one of the questions that you all have been asking, can I use my 2026 manuals? The first answer is contact AAPC. Contact AAPC and find out when they're changing their exam, because sometimes it's to your advantage to use a 2025 or the year before manual if it's at the beginning of the year, because they often don't change their exam until like March or April. So ask them if you can use your 2025 manuals. And that's all I want to say. All right, so this is week 3. We're going to focus. Look at this. I changed this. I don't know why it won't change. All right, so this week 3, we're going to focus on cardiovascular system, right? Our focus is going to be on key guidelines with coding nuances. We are going to focus on FTRs when applicable, key modifiers when applicable, application to practice, and we hopefully will bring you one step closer to medical coding mastery. Yes, this is week 3, cardiovascular system. We're looking at the MCDC course, their LMS. You got a few things to do. So follow your work in the order presented. And don't forget that you now have an RSVP module. And there you can find all of the links and the playbacks to your group studies, your 30/30s, your whatever you need to come to, your YouTube. You can find it here. And this is for MCDC Platinum students, okay? And remember, it turns green when you've finished the module. Now, this is what the gold students module looks like. Just follow your course in order and you are good. Now, people want to know what's the difference between the two. Well, there's a big difference. The MCDC course, of course, costs a lot more, but you have more instruction, you have private group studies, quizzes, and reading is not essential. No, the readings are not. In fact, in 2027, well, 2026, the readings will be optional. In 2027, they're going to go away, possibly. All right, so the gold course students, your videos are only from YouTube for the most part. We might have put a few private in there, but that's where um, your lectures come from. You have quizzes that are integrated. Yes. You know what, too? This I don't know why, but this is missing. You have exams in the MCDC. Everything is put where it should be. So I do apologize for that. And if you are in the gold course, readings are essential because there's some things that may be missing. So you need that bridge. Okay. Hopefully that makes sense. All right. So if you have any questions, about your LMS, go ahead and type in the chat. And there is a question. All right, so somebody say, hey, they're in part 2. This might be a little more advanced, but stay, just stay. And in 2026, our class is going to change a bit. We're going to have discussions for parts 1, 2, and 3. So we're going to guide all of you. You are absolutely welcome. All right, so today, everyone, the world can come to our class because there was a little mishap. I'm not sure why the reusable link is not allowing me to go live. So everybody benefits from the mishap, right? Yeah. Okay, let's get started and let's talk about cardiovascular system. And, we kind of, remember, we kind of review these guidelines, but we're not going to review them in depth. But just to let you know that the general surgery guidelines apply to these cardiovascular system guidelines. They do, right? So always apply them if they apply, right? If it applies, apply them. And yes, the specific guidelines will supersede if they contradict one another. All right? All right, so let's begin with the table of contents. And these make if I cannot impress enough that you should always look at your table of contents so you can become familiar with the procedures, right? So in the heart and pericardium, these are the procedures. And there are a few. And then you have arteries and veins. And then the mediastinum and diaphragm have procedures. So basically you have your coronary procedures and your arteries and veins. And then the mediastinum and diaphragm. And they have really nice, I like their anatomy because it's really easy to kind of see. It's easy for me. And also, if you want to make documentation on it, you can. And it's perfectly okay when you take your exam. So, no, this is not a comprehensive list of the circulatory system, the arteries, and this is not a comprehensive list of the veins. It isn't, right? And these are your lymph nodes. But if you need to adjust it and write, you can. You know what? I don't see my, oh, and don't forget your heart, the anatomy of the heart. I kind of, there it is right there. Um, don't forget that. This is important and it's here. And in some of the videos, I number them. So when you watch the cardiovascular system videos, the introductory, I know I do it. And also in MCDC, I also do it. But if it's not in on any of the YouTube videos, I'm pretty sure it's somewhere. I just can't tell you where. All right. And if you need it, just, write, send me a message and let me know in the at the end of session I'm going to ask you to complete the survey. All right, so I want to know what you already know. Remember, this is not re-instruction. No. So I want to know what you already know. Okay? About pacemakers of the following, which best represents a true statement about coding pacemakers? Go ahead, type your answers in the chat. A. You may use the CPT pacemaker chart for open pacemaker procedures. B. A pacemaker pulse generator is a battery. C. Only report pacemaker generator replacement when the battery is fully depleted and no lead work is performed. D. Transvenous pacemakers are inserted through the chest. A, B, C, or D? What say you? Yes, someone said, can you take the banner down? Absolutely. My pleasure. Thank you for letting me know. All right, go ahead, get that answer in the chat. All right, so if you don't know, you will. All right, so a pacemaker, pulse generator, that's a battery. So when you see that language, just know that they're only talking about a battery. Right. Good job. Good job. I think I'm a little delayed. So please forgive me. All right. So if you want to read ahead, go ahead because I am slightly delayed. Good job. Look at those answers coming through. That's what I'm talking about. All right. So, of the following, which best represents the most accurate statements about coding a CABG or coronary artery bypass grafts? A. Code selection is based only on whether the graft is arterial and venous grafts are included automatically. B. Each coronary artery bypass graft is coded separately, regardless of whether the graft is arterial or venous. C. Code selection is based on the number of sites bypassed and the type of graft material used, whether arterial or venous. And D. Only venous grafts are reported because arterial grafts are always bundled into the primary CABG code. What say you? And those answers are coming through. And the answer is C. Yes, these cabbages are coded according to the number of sites bypass. Is it times one, two, three? You ever hear of triple bypass, quadruple bypass, double bypass? That's what they're talking about. And the type of graft material. Are they using an artery or a vein? That is the correct answer. Great job, everybody. All right. Final question. Now, this is on diagnostic studies of the cervical cerebral arteries. What do you already know? Of the following, which best represents the most accurate guideline for diagnostic studies of the cervical cerebral arteries? A. Code selection is based solely on the number of images taken, regardless of the catheter placement. B. Selective catheter placement is when the catheter does not go beyond the aorta. C. Catheter placement must always be coded separately from diagnostic cervical cerebral angiography because it's never included. Or D. Example of non-selective catheter placement is when the catheter does not go beyond the femoral aorta. What say you? Wow, look at that. Miss Shayna, outstanding from the Bahamas, says she passed her CPC exam using this content. AMCI. Thank you for letting us know. And please go to our website, www.amcicoding.com. And at the top, there is a link where you can let us know. We will acknowledge you and you will be considered an AMCI alumni. So thank you so much, Ms. Shana. And the chat is congratulating you too. That is incredible. Okay, coders, put your answers in the chat. What say you? What do you already know? And I see some answers coming through. What do you say? What do you say? Yeah, it's D, an example of non-selective catheter placement. The key is that catheter, if it's non-selective, it does not go past the aorta. And remember, that aorta goes all the way up and down your trunk. So yeah, we have a femoral aorta. Absolutely. Outstanding answers, D. All right, so now we're going to talk about something that we typically don't. We don't really have long conversations about coronary valves. And the team, if you can recall the last time that we have, definitely let me know. But we are going to dive deep into these coronary valves. And just so you know, you've got four of them, right? So your heart has four valves. We know that, right? Remember, if definitely if you're an MCDC student, you know we talked about chamber, valve, chamber, valve, or chamber, door, chamber, door. The doors are the valves, and you've got four of them. So when you go from the um, atrium the right atrium into the right ventricle, you got to go through a door, right? Yeah. And this first door is the tricuspid valve. Looks like a little something, little part of the anatomy right there. And then when that blood leaves the ventricle, the right ventricle, it's got to go through a door. And this door right here is the pulmonary valve, and then it goes to the lungs, comes back through, enters through the mitral valve, and then that blood goes to the rest of the body through the aortic valve. So you've got four valves: pulmonary, tricuspid, aorta, and mitral. And sometimes these valves, they become diseased and they have issues, right? So the most common issues are stenosis or regurgitation. When it's stenosis, that valve is too narrow. And when it's regurgitation, it's too leaky. It's too wide, right? So a patient might need a valve replacement. And often they'll have a replacement, or what is it called? It's not like an, mm, I would say it's not a replacement. We're going to get to it, but one second. Yes, they're either going to have a replacement or an implantation. Okay, so generally, your valves become defective, with aging and wear and tear. Or if you have congenital defects, you're born with a valve condition, or even an infection like endocarditis, that can cause your valves to have issue. Also, rheumatic fever, degenerative changes, and heart muscle disorders. These can all cause either of these conditions. Now, the procedures to correct these conditions are one of two. Either you're going to have an open heart valve procedure or a transcatheter procedure through the catheter. And open is what it says. They're going to go through your chest. They're going to incise you, you know, at the chest and repair it. And transcatheter is exactly what it's saying. They're going to go through a catheter and repair it. So let's take a look at the open procedure, just kind of give you a little context. This is a traditional surgical approach. The chest is open, usually with a sternotomy. The patient is placed on a cardio bypass machine. That aorta is open. The diseased valve is removed, a new valve is sutured in place, and your procedure codes are essentially 33405 through 33430, and that's for the aortic valve, and then you've got your mitral valve, and then you have other, your tricuspid and the aorta, tricuspid, and mitral. Okay. Yeah, aortic. Huh. Which one did I miss? Type in the chat. Which one did I miss? Pulmonary. Yes, somebody said they remembered the acronym. Go ahead and type it in the chat, Ms. Leslie. Let me know. All right, so this is your standard open valve procedure. Now let's take a look at the transcatheter valve procedure. They're called TAVR or TAVI. That's what I call it anyway. And essentially, to know the difference, a transcatheter is through the catheter. There's no sternotomy, no open chest. A catheter is inserted through a blood vessel, usually the femoral artery. The replacement valve is delivered through the catheter and it expands and anchors inside an old valve. And there's your code series 33361, 333366. And this is for the, trust me, this is not the comprehensive list, but this is an example of a code series. And it's either going to be a TAVR or a TAV. And a TAVR is when you are replacing the valve, and a TAV, that's implanting or implantation. Now, I did take the time to kind of look at these guidelines, and they are very, very extensive. And I think that might have been one of the reasons why we just did not, touch it, because really it's not complex, but it got a ton of guidelines. The mitral valve have their guidelines, aorta, pulmonary, and tricuspid all have their own guidelines, but the majority of the guidelines are not pertinent to the open procedures, but more so those TAVI and TAVRs, those transcatheter procedures. Essentially, I came up with this kind of quick reference chart for you to kind of look at, just so you can see what is bundled and what is not, and basically what the procedures are that are commonly associated with this transcatheter. And I'm very specific, not the open, the transcatheter. Essentially, percutaneous access and sheath placement is included in the code. It's bundled. Your balloon valvuloplasty bundled. Your valve deployment and repositioning bundled. Now, sometimes they'll place a temporary pacemaker. They'll insert it. That is not reported at all. Okay? So you're not reporting it is bundled, and you're not reporting that pacemaker. So you're not coding an additional pacemaker. All right, the closure of the arteriotomy, that's bundled. All the imaging guidance, it is bundled. Your approach, of course, that's bundled, right? Your coronary angiography, sometimes it's bundled, sometimes it isn't. It only depends. You have to pay attention to the code language. Also, your cerebral embolic protection, that is not bundled. You have to code that additionally. Your VAD or balloon pump support, you code it additionally. Cardio bypass, you code it additionally because there's an add-on code. All right. And multiple valves, you use the additional codes as well as modifier 51. So these are general guidelines when you're coding for valves and specifically within the catheter. If you have any questions, go ahead, type in the chat. All right, we got a scenario. We're getting into it. And you know where this scenario came from? This scenario came from the AMCI, those big scenarios. I said, let's go ahead and tackle it. Are you all ready? This is a big one. All right. Okay. Of the following answers, select the correct CPT code for this procedure. A, 33365, 33367, B, 33365, 33368, C, 33405, and D, 33410. And if you want to read ahead, go ahead and solve it. Go ahead. Indication: aortic valve stenosis. This patient's got this condition. Operative details: the patient was taken to the OR suite, placed in supine on the operating table, and general anesthesia was induced. A median sternotomy was performed, and the pericardium was opened to expose the heart. heparin was administered to prevent clotting, and the patient was cannulated for cardiopulmonary bypass or CPB. Once CPB was initiated and the heart was arrested, the aorta was cross-clamped. The aortic root was opened to expose the aortic valve. The diseased aortic valve leaflets were excised. The annulus was sized and the selected stentless tissue valve was implanted with a continuous suture technique. The aorta was then closed and the heart was reperfused. After reperfusion, the patient was weaned from CPB without difficulty. The cannulae or cannulae were removed, or cannula. Heparin was reversed, and the chest was closed in layers using a standard technique. Hemostasis was satisfactory. The patient tolerated the procedure well with no immediate complications. The patient was then transported to the ICU for closed post-operative monitoring. Okay, coders. Now, you all can wait for me to solve it or you can solve it, but I know when I was studying for the exams, I did not like these long scenarios because they were not short. The shorter ones were easier to do, right? Yeah. And on purpose, the name of this procedure is not here. So you're going to have to break out those keywords, write down the keywords, and solve. So walk with me. We're going to take a walk through this scenario, this long scenario, because I kind of want to demonstrate for you that there are things that you should eliminate. You don't need to code for. We know some things because we've been studying with Mr. Sandeep. We've learned some things in class. We know we don't code hemostasis, right? We know we don't code closures. We know we don't code incisions to the incision to in excuse me to access the surgical site. We just don't. We know that, right? But this is a lot, right? So what I've done was I've taken that procedure and I've written down the diagnosis and every single thing pertinent item that was carried out just to kind of walk you through this procedure. So at number one, we had an aortic valve diagnosis. We know that stenosis as our diagnosis. We know this is the reason for the surgery. Then we had a median sternotomy, opening of the pericardium. Heparin was administered. Cannulation took place. Initiation of CPM, cardiac arrest. What? Aortic cross clamping, aortic root incision, excision of those diseased valve leaflets, sizing of the aortic annulus, implantation of this tissue valve, closure of the aorta, cardiac reperfusion, weaning from CPB, removal of cannulae, reversal of heparin, hemostasis, and layered closure of the chest. These all happen. Now let's go ahead and walk it through. And somebody said, hey, it looks extra tiny. So that has to be maybe the way you're coming in. There may be two. So you might need to click the other link. And team, if someone can verify if my screen is small or not. Yes, you are. I see a little image next to you. So if you go back to YouTube, you're going to see another option for this presentation. So click the other one. It'll give you a bigger view. Thank you. Yes, I can see that you're there. All right, so let's go ahead and let's do this surgery. This patient had a medial sternotomy. So that means that the doctor incised the sternum area right there. See the little, that's where the doctor cut. Then after the doctor cut, the patient open to expose the surgical site, that pericardium was incised also so that they can access the surgical site even more. So we know that these items are kind of bundled. I do. You're not going to code accessing the surgical site, right? So yeah, let's go ahead and get rid of those two. All right, you with me? Okay. Next, heparin was administered. Now, heparin is administered to prevent the blood from clotting while the patient is on cardio bypass, right? On that bypass machine, and we're going to get to it. But that was the medication that was used to prevent blood clotting, heparin. Next, cannulation took place. What is that? A cannula. When you hear that term cannula, that's a catheter, right? So they inserted catheters into it looks like right here, inferior vena cava, and that looks like the superior vena cava. They inserted it to get ready for the cardiopulmonary bypass machine. Yes. So that is you might not want to cross it out, but I feel we need to cross it out, and I'm going to tell you why. But you would code for it in certain circumstances additionally, but not in this one, and I'm going to tell you why. All right, so and then after they get the cannula in there, they go ahead and they begin the initiation of the cardiopulmonary bypass machine. And basically, this machine is taking over the work of the heart and the lungs. They're taking over everything so that the surgeon can operate on a still and bloodless heart. Yes. You know you don't need a heart beating while you're having surgery. That would be reckless, right? That doctor needs the most steady um, heart so they can operate with precision. So the machine is now doing the work. All right. So cardiopulmonary bypass, we're not in this case coding for it. Now, when the cardiopulmonary bypass machine is on, the doctors induce cardiac arrest. Yes, they want to safely make that heart stop and protect the heart muscle while the surgeon is working on the valve. We got to protect that muscle because if we don't, that infarction can set in or a heart attack and we can have more complications. So how they do it, they take a special potassium rich solution and the doctor infuses it, as in this picture, into the heart. And they um, induce cardiac arrest to stop that heart from beating. Yes, the machine is doing the work. And then they move on to aortic cross clamping. Yes, they want to stop the blood flow. So they're going to cross clamp it so that the heart can be kept still and bloodless throughout this valve procedure. And no, we're not going to code for it, putting a line through it. Now it's time for the procedure. And the first step is to incise, right? Incise the aortic root. So they're still trying to access the surgical site. And you know what? You don't code it. When you're accessing the surgical site, you typically don't. So I'm going to cross it out. And that leaves us with our main procedure, excision. It's not necessarily the main procedure, but it is a main procedure because this is where they are going to excise or get rid of that diseased valve. Are we going to code for it? Maybe, maybe not. But I'm going to leave it. And I'm going to leave it for a few reasons. Next, after they excise the valve, they need to size the aortic annulus. So basically, they have to size it up to make sure that the prosthesis fits, right? We're not going to code for that. It should be bundled in the code. It should be, right? And then after they size it up, it's time to do the implantation. So in our case, we had a stentless tissue valve using continuous sutures. So that is the implant, and that was is what took place. So this is the best image that I could get of a tissue valve using continuous sutures. So they repaired the valve. It is no longer looking like it did previously. So if this patient had stenosis, that means it was closed maybe too tight. So they replaced it and opened it up for blood flow. And then after the implantation took place, they got to close the surgical site, and they closed the aorta, and we call that an aortotomy, right? So no, opening and closing the surgical site is not coded, not typically, but sometimes it could be. Some of the codes are built, you might have patchwork, and some of the codes might say using a blood patch, etc. So it's just a matter of reading the code language, but generally you wouldn't. After the closure, we have the reperfusion, right? So cardiac reperfusion is the moment during open heart surgery when the blood flow is restored. So as you've seen earlier, they've taken a lot of measures to stop the blood flow. Now it's time to get that blood flow back. And the first thing that they do is remove that cross clamp. So we're not going to code for reperfusion. That should be bundled into the surgery. Next thing they're going to do is wean the patient off of the cardiopulmonary bypass, and they do it slowly. They transition it back to full workload. And the reason is they want to ensure that that patient's heartbeat is strong and stable before removing them completely off of the bypass. And no, that is not coded separately. So we're going to, get rid of it. And then a few things took place. They're going to remove the cannulae the um, the heart, the this corn the cardiopulmonary bypass machine, where they inserted the cannula or the catheters. They're going to remove it, right? They're also going to they're going to remove the cannulae. They're going to reverse the heparin, and they're going to carry out hemostasis. This is hemostasis. So hemostasis can be anything that the doctor chooses. It could even be electrocautery, etc. So those three things took place. And then finally, they're going to carry out layered closure of the chest. They're going to close it back up. So let's take a look at everything. All right, so this is what it looks like. So for me, I would keep 1, 10, and 12. And some of you might say, hey, I'm not sure. If you're not sure, leave what you're not sure about because it will never hurt. It would never hurt. So let me go ahead and provide you with my inventory. The patient has aortic stenosis, excision of the diseased aortic valve leaflets, and then implantation of a stentless tissue valve using continuous sutures. Now, I'm going to go and just go to where the codes are, right? And these codes in the first set, these are transcatheter, and the second are open. So my first question is, was this an open procedure or a transcatheter procedure? Go ahead, type in the chat. Type in the chat. Was it transcatheter procedure through the catheter, or was it an open procedure? Those answers are starting to come through. Okay, run with Britters and Bree Nicole and B. Frazier and Vina D. Yes. You know what they're saying? They're saying, hey, this is an open procedure. They knew that a median sternotomy was performed and the pericardium was opened. This is open. They went through the chest. And if it's open, it's not transcatheter. So we can eliminate the transcatheter codes. 3365. This is the code for transcatheter aortic valve replacement with prosthetic valve, trans-aortic approach, median sternotomy. So you might say, hey, this looks, this is a little confusing. Just remember, we got to focus on that transcatheter. Yes, sometimes they do open you up through the chest to insert the catheter. Sometimes they do. Okay? And often they do. Okay. So let's go ahead and get rid of 33365. Now we're left with 33405 and 33410. And it's just a matter of us reading. And 33405 is the code for replacement of aortic valve open with cardiopulmonary bypass with prosthetic valve other than homograft or stentless valve. Okay, so coders, this looked like it could be it, but 33410 looks like it is it because it has more keywords. This is the code for with stentless tissue valve, right? That's exactly our procedure. So we're going to go ahead and get rid of 33405 and 33410. That's our answer. And if you said 33410, outstanding encoders, let me tell you something. The biggest takeaway when coding these valves, first of all, they are straightforward. And when you take your exam, it will not be this extensive, right? When you take your exam, 9 times out of 10, they're going to just tell you that it was an open, they'll name the procedure. They'll say replacement of this, but this scenario on purpose didn't say it. You kind of had to figure it out. You know what I mean? Up at the top, typically they'll tell you, but you kind of had to just read through the language. And you all did a phenomenal job. But the key takeaways, you need to know which valve it is. Is it the aorta, mitral, pulmonary, tricuspid? Which valve? That's 25%. And then you need to determine if the procedure was transcatheter or open. It's direct open. Which one? Transcatheter or directly open? And that's 75%. And that's it. That's all I got for you today because, we can't stay here all day. I only have 1 hour with you, and I am always, always happy to spend as much time and give you what I can. So this was a teachable moment for me to kind of break down this valve surgery. It doesn't have nearly the guidelines that we thought, but those two things is what you need to remember, and you're gonna breeze through these. You are, and in the real world, you're going to be able to break down that documentation. So I just want to say thank you, and don't forget to complete the survey. Last week, guess what? Not one person completed that survey. Maybe it was me. Maybe there were only 10 people here though. But you help us when you fill out this survey. You let me know that you're in that chat. And it's also, if it's telling me what you need, I need to hear it. If it's just telling me how you're progressing, I need to hear that too. If there's anything we can give you, or do for you, I need to know. If you don't tell me, I won't know. So I want to thank you. I want to thank my team. Team, you are amazing. Thank you, Ms. Mills, Mr. Sandeep, Ms. Dolly, Miss Leslie. Thank you too. Thank you, coders. True Fudge, good to see you. Thank you, Miss Kim Hartman. We have a new member. DC Kicks, I missed you. Good to see you. And if you all need anything, we are here. Zalma Vasquez, welcome back. I missed you last week. All right. So if you need anything, just fill it out on our survey. And we're going to see you next week and next week. Not next week. No, 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 no. The week after. And next week, we are on break for the holiday. And we'll see you the following week. And have an awesome day.